So in the next 15 minutes or so, I kind of really down it to a couple goals here. One is, why are ED handoffs, and particularly transitions of care, we'll just kind of broaden it a little bit, especially important now in this time of history. And then, kind of bottom line stuff. What are the practices for ED handoffs to other ER physicians, to hospitalists, to consultants, and then discharge back to primary care or their provider in the community. So a little history. So it was really only about 7 years ago that it kind of started getting steam, this idea of handoffs, and we got to concentrate on handoffs. And that all kind of stemmed from National Patient Safety Goal 2E, which is essentially you need a standardized approach, which is kind of controversial actually. You need a standardized approach to handoffs with an opportunity to ask and answer questions. So the Joint Commission picked this up, became a big emphasis 2006, 2007. The WHO starts making transitions a real high priority, top 5 of their patient safety priorities. Then the ACGME, which is the organization that kind of governs residency programs, in 2010 said that it's going to be mandated that we're going to have to teach all our residents that. So last year we were over at CORD kind of teaching residents and residency directors how to hand off. And this is a little bit in response to kind of a backlash what happened in 2003 when they had all of a sudden the 80-hour work week, right? So all of a sudden they found, not only do we need more workers and hence mid-levels and other sources of, less expensive workforce, but they also found out there's more handoffs, because if your surgical residents were on Q2, and they were only, Q4 or Q5, there were just more patients, more handoffs, and they need to get better at doing it. And probably most relevant to us is that the ACA healthcare reform makes a very high priority on care coordination and transition of care. And so we'll talk a little about that. So Dr. Seberg was actually in the back room, said, hey, I saw your slides and you're quoting me. And I said, that's a compliment, right? I wasn't there at the 2011 address, but read it later. And this is kind of an overarching kind of theme that I kind of want to use for this little talk here, is that emergency physicians must consider stepping out of our perceived comfort zone and perception only of providing acute care. So we're kind of used to viewing emergency medicine as an island. We're a silo. It's us versus them. We chose emergency medicine because we like it this way. We show up for our shift and then we leave and leave all the worries behind. And that's certainly true. But I think if we're going to prove our value in emergency medicine in the future, we got to learn how to be better teammates. We have to think, okay, we are a bridge. We're kind of a hub to other services. So we're a hub to the PCP, because we receive patients from them. We're a hub to the inpatient service because the vast majority of admissions come through the emergency department. And if you look at, if you take OB out of there, we're a vast majority of admissions to the hospital. And then back to the primary care world. So that's how kind of organized my talk. The emergency physician sort of at the hub, and then the PCP, the emergency physician, consulting physician, and admitting physician kind of on the outside. So first, focusing on the emergency physician to emergency physician handoff. And this is kind of where I got my start. Like Sherry mentioned about, I started getting handoffs about 4 years ago. It was kind of serendipitous, It's kind of one of these things where, one thing leads to another, and all of a sudden you find yourself in some, in some managerial position. You don't know how you got there, but then you're there. And then all of a sudden, tasks coming down the line, and they said, we have the section grant, can you administer it, blah, blah, blah. And I said, sure, what's it about? And he goes, it's about handoffs. Because I know nothing about handoffs. And I'm not actually that interested in handoffs. But if you need a project manager, I'm happy to be your project manager. I run these things, that's fine. And the kind of funny thing is that I became actually very, very interested in handoffs and very, very interested in transitions. And that's sort of kind of taken over my life. But this paper, which Sherry mentioned, I'm not sure if it's a definitive paper, but it's a well-known one out there. And a lot of the credit, really, it was a group effort. It was from the section of quality improvement and patient safety. 25% of the authors here were in this room at some point during this conference. We really kind of shaped a lot of the thinking about handoffs in ED. So part of that grant was we did an ACEP Council survey back in 2008, and we got tremendous turnout, mainly because we had all our members spread out and handing people and getting them back. So we had like a 75% return rate. And the couple of surprising findings. One is that the median, at least 50% of the people, at least at council in their hospitals, had less than 5 handoffs per shift, which was kind of interesting because, then there was the opposite extreme where about 5% of the hospitals had greater than 30 per shift on average. Now I've kind of worked in both shops. Like right now I get maybe two to 5, but I've worked in those big high volume shops where you're signing out everybody and it's huge. The other thing that was really kind of surprising was that there's widely varying practices. It's not so surprising. We did a similar survey at CORD, which is Council of Residency Directors. Back in 2011, we got 147 responses, which is about half of the GME programs. And the real surprising finding here was that only 3% or so said that their handoff system was effective. So I'll just kind of get to the bottom line here. So we came out with a bunch of recommendations at the end of our paper, of that white paper, and this is what kind of came down to. Best practices: try to reduce the number of unnecessary handoffs if possible. If possible. Okay, you don't want to, not hand off a patient or truncate a workup or speed them along just to avoid a handoff. But if you can, systematically try to avoid unnecessary handoffs. So a couple suggestions for that: overlapping shifts, so that when you end at 7, it's not like the person's coming in at 7; they're coming in at 6 or 5. Or at a certain point at the end of your shift, you start picking up the fast track patients. You don't pick up the 86-year-old altered mental status. You don't pick up the septic patient. You try to be very selective on who you pick up. Second, it's kind of a no-brainer, but limit interruptions and distractions. Easier said than done, especially in a busy emergency department. I mean, I know the nurses on the floor get a lot of flack for saying, we can't take report or whatever because we're in sign-out and stuff like that. And I can't justify everything they do, but we do have to adopt, for 10 minutes, we're going to talk because this is really important and this is a very kind of dangerous procedure that we do, perhaps the most dangerous procedure we do during the course of our shift. Third, structure the order of the handoff. So there's many ways to do this, but it's essentially structure the order because it's much easier to catch a pass when you can anticipate where it's coming from. Right? So if the person's signing out to you, you don't want to go, okay, this person and this person's sick, this person's not sick, this person's room 3, room 12. I mean, it's all over the place. It's really hard to kind of keep track, right? So the ways you can structure the handoff are start with the sickest and go down to the least sick. You could do geographic. So if you have a large ER, start from one end of the room, go to the other. For people on EHRs, you just kind of click and you go to all your providers and go from top of the screen to the bottom screen, but you've got to find some way to structure the handoff. And the idea behind this is you don't want to forget anybody too, okay? So, and I'll talk about later about who are the ones that we typically forget. Fourth, provide a succinct overview. So you want a blanket statement, 41-year-old, atypical chest pain, no cardiac risk factors, going off stress test. If it's negative, you can discharge them, okay? You don't want a bunch of details. I remember when I was a resident or even a junior attending, it was kind of a badge of honor, a badge of pride to see how much detail I could give about every patient because it showed how well I knew them. On the receiving end, you don't want to hear that. You're not going to remember that. You want you want a nugget, you want something to pin that patient in your memory for the future. Fifth, communicating outstanding tasks. And that's real important because part of a handoff is transferring responsibility, authority, and it's yours. So what are you going to be responsible? What am I going to be responsible for? The last one, on this slide at least, is best practice. Make information available for direct review. So it's really easy now with electronic medical records, with PACS systems. The more that the person who's receiving it can kind of make sense of the objective data themselves, the better the handoff goes. So it's kind of nice if somebody's kind of speaking in your ear, whispering the narrative of the patient, and you're sitting there kind of looking at the EKG, looking at the labs, looking at the radiology exams yourself. And then finally, encourage questioning and discussion of assessments. And this we just don't do well. I mean, as many times as you tell people, make a period for questions and answers, people just don't do it. because you're usually kind of overwhelmed a little bit when you're hearing it, right? And you got one ear listening for the patients who are coming through the door, and then other ear for the patients that you're responsible for. One best practice that we kind of talked about, and which I highly encourage, is make yourself available later on for questions and assessment. So kind of ER culture is, when I leave the door, you can't reach me. I'm gone. So because a lot of times the questions come up later, 5 minutes, 10 minutes later. So leave a phone number, some way that you can get in contact. Second, account for all patients. I alluded to this earlier. So the high-risk patients, it was kind of funny on this call with 25 people, and we did this over the course of like 6 months. One of the recurring themes was, and people first were embarrassed to admit it, but was like, I forgot about the patient. It's like halfway into my shift, who is this coming back from somewhere? Or somebody, when the people are lined in halls and stuff like that, you find out, at 4 o'clock in the morning, who's left? And then you're finding, does anybody know this guy? He's been sleeping for the past 8 hours, right? So one of the most basic things is account for all patients. Now, high-risk patients that we will tend to forget about are the people that leave the emergency department, so they're off on dialysis or radiology study or something, and they're out for hours, and then it's like they come back, and you forgot them because out of sight, out of mind, right? Other people that are high risk are patients who are admitted. So, we easy go, oh, this one's easy, they're admitted, But with boarding now, they could be there for hours, if not days, right? And so we know nothing about that patient that is admitted and boarded. Discharge patients as well. So we like to, try to make it really neat, that the patient's kind of like all wrapped up and ready to go, they're appropriately dispositioned, but then something happens, right? And so those are the patients that biggest headache, because it's like, I thought they were gone. I know nothing about them, right? And the nurse says, well, they're vomiting now. What do I do? And he goes, who are they? So there's another set of patients. Another one that has kind of come up recently with the advent of mid-levels is the mid-level patients. So it's, sometimes the mid-levels see their own patients, they see in concordance with us, and then when you sign out, it's like the mid-level leaves or the mid-level gets problems with the patient, and you're like, who are they? And so one of our partners always tries to sign out, oh, you don't have to worry about them, it's a mid-level patient. Well, now it's my patient, it's change of shift, and I need to know everybody. Last thing is, give up the reluctance to take ownership of the patient. So, again, I think it's natural habit when you come onto shift. You want the patient's disposition to be clear. I don't care what the disposition is, but it's got to be clear. They got to be dead. They got to be, going to the ICU. They're going home. I don't care, but the disposition's got to be clear, right? So sometimes they're just not clear, or something comes up. They were discharged. The instructions were set, but they're not going, right? So we really resist the temptation to avoid taking ownership of the patient after they leave. So some controversial stuff, standardization, how much do standardization? It's kind of funny because at the ACEP Council, when we asked them, how would you fix handoffs? 2/3 of them said, oh, just standardize it, It's like that's easy. And it's kind of interesting because on our panel of experts, it was like, you can't standardize this, and also you don't want to standardize it for everybody, so you're going through this litany of stuff that you don't want to know for every patient. It's like always the creatinine, always give me this, always give me that, so you want patients that are tucked away, that are not acute, short, and then other people you need to talk about it longer. We won't go through the other controversies for now, just for sake of time. So, one thing leads to another. And a couple years later, it said, the EP handoffs, that was all great, but we also hand off a lot to admitting patients. That's where it kind of a little comes dicey, because they're not always on our team. We get into conflicts, and so a group of us said, okay, we really got to focus on handoffs to hospitalists. So this was kind of a very interesting group. We just published this about 6 months ago. And it was a group of emergency physicians and a group of hospitalists. And then we had 2 communication experts on our team as well, who were Emily Patterson and Julie Apker, who are just phenomenal and have published a lot, especially not only in healthcare, but especially this transition between emergency physicians and hospice, or between emergency physicians. Then we kind of had an interesting grouping. So the emergency physicians are in blue, the hospitalists are in red, and we specifically picked these teams because all of us were very interested in handoffs. All of us had published in the handoff literature. But Chris was, at Northwestern, and he was the lead author and lead of this project. And Chris worked with Mark Williams and Kevin O'Leary. So if you don't know Mark Williams is the editor-in-chief of their hospitalist medicine. He was the previous president of SHM, Society for Hospital Medicine, similar to our ACEP. And my counterpart was Eric Howell over at Hopkins. And he kind of started up the hospitalist medicine program over at Hopkins. He's done a lot of stuff, really good stuff with active bed management, which I'm not sure if you read about. But great proponent of the emergency department. And then Jay Shore was matched up with Leora Horowitz, because at his time at Yale when he was doing his RWJ fellowship there, Leora was also there doing her RWJ fellowship, and she has published quite a bit, actually, in emergency to primary care and emergency to hospitalist transitions. So it's kind of interesting. And then Bob, well, Bob just knows everybody. But anyways, that's Bob Wares. So it was kind of very interesting because over the course of 9 months, we would have these bi-weekly meetings, and it was a friendly crowd. I mean, we handpicked these people. We're generally very hospitalist friendly. They were generally very ER friendly, and we just kind of sat at the table for a couple hours every couple of weeks and hashed over certain things. It's like, okay, we got to get our people together because, our relationship isn't always the most friendly with the hospitalists, and so we got to sit down and figure some stuff out. So the first thing we did was we tried to have each other's side explain what was it like to be an emergency physician, okay? So let us tell our side, and then let's hear your side and see, where we can find common ground and why there is conflict. So a whole list of things, but I'll just focus on 3 here. So the emergency physician, by training, we focus on the immediate next step. We don't know their diagnosis all the time. We don't know their eventual disposition, but we know what to do in the next hour, So, and that's our focus. For example, pneumonia, right? We don't care about blood cultures because, if you bring up blood cultures or the blood culture core measures to an emergency medicine group, it's kind of a non-starter, It's kind of like, it really kind of sours the conversation, right? Because we don't care about blood cultures. We don't see them, we don't react to them, and for us, they're kind of useless. They rarely come back positive, right? But for the hospitalists, they also realize, it doesn't come back positive that often, but when it does, it's really helpful. Because the triple antibiotics you started them on, I can narrow it down to 1, or the influenza that came back positive, I can stop the antibiotics. So it's a kind of real big deal for them. For us, by training, again, we're comfortable with limited data in an evolving clinical course, so we're just used to it. It's part of our nature. Ambulance comes through the door, they're altered, we have no history, and we're good with that, we're kind of used to it, right? You can't get water out of a rock, right? So we don't worry about it, We can't get old records, most of our patients. Even if they have old records, we can't access them, right? So we're kind of comfortable with that. The hospitalist really, really values data, concrete data, verification of that data, and that's just the way they're set. I think that's why certain people go into emergency medicine, some people go into internal medicine, because we're just kind of different mindsets. But it's important to hear that because if I have a person with chest pain coming to the emergency department, they had a stress test 6 months ago, but it's over at the county hospital and it's 3 o'clock in the morning, it's very unlikely I'm going to get those records, right? And it's kind of a scary story, so I'm going to admit that person. The hospitalist, on the other hand, says, it's worth going after that information because if we get that information, it's going to save a lot of hard work, unnecessary testing down the line and cost. And so we, both of us, I think, value efficiency. We both want to be efficient, right? I think our efficiency is kind of more in the short term. It's kind of like, I need to get this person out because I don't know who's coming through the door next, and there's that kind of anxiety, right? Because I gotta prepare, I gotta have some capacity or buffer to handle the next hit, right? And the hospitalists they also value efficiency, but they're kind of a little more longer term, kind of thinking, okay, well, if I do this now, it might save me 2-3 days down the line. Or it might save the PCP, they might not need a PICC line for a month, et cetera, et cetera. So they value efficiency too, and I think we need to respect that. And I think, again, kind of my themes that I started early in my talk was, we gotta get ourselves out of the silo of thinking, okay, they're in my ER for 2 hours, 4 hours, what's the best thing for them? And kind of expanding that buffer a little bit to thinking, okay, well, I got to think a little more long-term about my colleagues and about the patient because, it's everybody's resources, right? It's not just, it's off my plate, it's onto somebody else's plate. Okay, so best practices that we came up. So this came through hours and hours of listening to the hospitalist. Okay, well, in a handoff, what do you want? Really, what do you want? Because sometimes we get the feeling we're giving it to you, other times we're not giving it to you. So they said at the outstart, severity and stability. You gotta tell me if I gotta see this person now or I can wait a few hours. Because unbeknownst to me, especially in large centers, the hospitalist you call is not the hospitalist who takes care of them, okay? So they're like the triage hospitalist. They take the phone calls and they might hand it off to a resident, they might hand it off to another hospitalist, they might wait for a change of shift, and so they gotta know, do I need to see them now? Not only clinically, but are they gonna be mad? So don't set them up for failure saying that, oh, the hospitalist is gonna see you up right away, because it ain't gonna happen, right? Most of the time. So the thing was, please don't set us up for failure, because it's hard to recover from. Don't overstate the working diagnosis. So on the hospital side, they were saying, we know some of our colleagues, just ask you, so what do they got? What do they got? Just tell me what they got, right? And so we say, they got pneumonia, or they got this, they got that. We don't really know, because they might be a little hypoxic, maybe a little fever, equivocal chest x-ray. We're not really sure they have pneumonia. They might have a PE or they might be in failure or something like that. And so don't overstate the working diagnosis. Now, if you got the diagnosis, right on the spot, sure, let them know, give them your reasoning, but if you don't lead them to think that you're more certain than you are. And that was a really, really big take-home point. Another big take-home point was summarize everything, okay? I don't want to know the details. And this is kind of different because, a lot of times we trained in academic centers and we were talking to interns or residents who wanted to know everything, right? They wanted to know the entire physical exam. But now we're talking to like career hospitalists, right? So they don't want to know every detail. They kind of got to figure it out. They want to know what the summary is. In particular, what they said they cannot get out of the ED record is response to treatments. So they can tell when, what they were given, when they were given it, but they had a really hard time figuring out what happened when you gave it. When you gave that neb, what happened, right? Did they get worse? Did they get better? So that was a really, really big request. And then assignment for pending data and tasks, similar to emergency physicians, you gotta split it up. It's like, I'm okay sending them to the CT scanner on the way up to the floor, but I'm signing out, and so you got to pick it up, So they're really explicit, what tasks do you have? And then state unusual circumstances, DNR, isolation, they're demented and it's 3 o'clock in the morning and their family's going home, who knows the history, right? So passing on phone numbers, things like that, that's really important to them. So handoffs to consultants, making our third spoke of the wheel here. So a lot of this credit goes to Chad Kessler, who's done a lot of work in this area, and we just put out a paper in Annals this month. So if you get your Annals, we came up with a taxonomy of emergency department consultations, and how do you do it, And he talks specifically about the 5 C's model. We won't talk about what exactly is a consult. It's a long discussion. So consultation, the 5 C's. So contact, communicate, core question, collaborate, and closing the loop. So contact, really important, because a lot of times the consultants, you don't know, they don't know you. And I used to be very casual about who I was, friendly. Hi, this is Dixon. I'm at Sky Ridge. I'm requesting this, et cetera, et cetera. But they don't know who Dixon is, right? Are you the nurse? Are you the mid-level? Are you the attending physician? So now I go, I'm Dr. Chung, so not less, more formal, but they know who you are, right? And similar, when you're talking to somebody, you really want to find out who they are, because it kind of frames the conversation. And communicate, again, the main thing there being summarized. They don't want a litany of facts. And then this is the big thing. This is the really big thing, is that when we started talking around to the consultants, what they really, really wanted, and what really kind of annoyed them from the conversation with the emergency physicians is, what do you want from them, right? So you give them a long story, you give them a bunch of labs, x-rays, and it's like, okay, you gotta tell me, do you want me to come in? Do you need me to do a procedure? Do you just want me to follow up with them? What would you like from me? And that was really important. And then collaborate. So you kind of decide together, how are we gonna handle this clinical situation? How are we gonna manage this patient? So you have an open fracture at 3 o'clock in the morning, but we don't admit all open fractures. They don't all go to the OR. So it's like, okay, if it's a grade 1 open fracture, it's okay, put them in antibiotics and you're gonna see them in the office tomorrow. That's fine if it's Wednesday and they're gonna see in the office Thursday, but if it's Friday and they're not gonna see them till Monday, that's not such a great plan, right? So you kind of collaborate, how are we gonna solve this together? And finally, in closing the loop again, say, so I understand, I'm gonna put them on antibiotics here, right? And you're gonna see them tomorrow, right? At 9 a.m., right? Okay, just so that we're all clear here, okay? That's real important. So we kind of talked about this, best practices, speak their language. So if you're calling a hand surgeon, you want to go, they're a right hand, they injured their dominant right hand, they're a musician, because it kind of speaks their language. They want to know what their occupation is. They want to know, are they right-handed or left-handed? And build relationships. And this is the thing we got out with the hospitalist too. I think we really kind of underestimate the value of social relationships. I think I kind of really kind of, me and Eric Ahal, the hospitalist that we worked with on the PAL, kind of really developed a relationship of trust after a while, because, I go to the hospitalist bowling parties. They invite me and I go. So it's, when you're sharing, a drink with somebody, playing bowling, you kind of get that bond. We used to break crabs, with each other in Maryland. In Annapolis. And it's a real bonding experience, so you kind of really learn who they are, to trust them, okay, we might have arguments and stuff like that, but it's just kind of different perspectives, and let's come to a common ground here. Okay, so last, quote from Sue Nesda, who's the VP for Patient Safety at the AMA, and an emergency physician, says, right now it's hard to go home feeling good at the end of the day when you're worried about patients whom you discharge, because they go off to who knows where and what happens to them, right? And so this is kind of what I'm working on now, and a lot of this, well, I can't say I'm working on it. It's actually Julius Pham, who's at Hopkins, is working on it. He just received close to a 7-figure grant from HRQ to work on ED discharges that he started a couple months ago. And so there's 3 main areas that he's looking at. He says, really for discharging ER patients, there's really 3 barriers. One happens at discharge, kind of communicating to patients and educating them about their condition, about what to do about them. Coordinating care with other providers and services when they land, and then supporting post-ED discharge care, kind of that no man's land between you leaving the ER till you're landing somewhere else. And we really, I think emergency medicine need to take more ownership after they get discharged. We tend to go, okay, you get discharged, you're off, you're not our responsibility, you're in the court of the PCP or the specialists. But we really need to start thinking, how do we bridge that gap? Is it community paramedics? Do we send them out to the home? Is it for a phone call after their discharge? Do we have a follow-up clinic in the emergency department, that we schedule? And you can mirror it with handoffs, so it's maybe the last 2 hours of your shift or something. So as you're cleaning things up, you're kind of seeing these follow-up wound checks and things like that. So this is just a graph of how he organizes it. And some examples. And so, he asks for suggestions. So we've polled and we've solicited many groups that are interested in ED discharge. And if you have any suggestions, anything that works at your shop, especially that's not published, because we kind of got the published literature under our belt, But if you guys are doing something really innovative and it works, please, please let me know, because over the next 3-4 months, we're going to come up with a plan to figure out what can we test. And we have a good budget to do this. He's got a lot of experts. He's got a lot of support to do this, and it's just one really great opportunity to figure out what works, what doesn't work. So my time's up. So, and that day's over. I really thank you for staying. I know it's been a really long day. You folks are probably the same people that sit in the front row in school, but appreciate your time. And if you have questions, please email me, and it's at the end. Thank you.